This episode is sponsored by PAX, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PAX. Every bag is handcrafted by expert tailors who understand the demands of post-op care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PAX absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PAX bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PAX doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PAX are built to perform, made to last. Learn more at pax.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. I'm here with Radu Venter. He is a paramedic from Canada. We're going to tackle another one of his blog posts that he's written on Substack. He goes by the pseudonym of the Paramedic Philosopher. Radu, welcome to the podcast.
Good to be back. Thanks for having me.
Radu, I just wondered if we could just unpick this fantastic blog post, which is No One Dies from Pain. You know, you really call forth in the piece that actually, although pain isn't necessarily immediately fatal, but dismissing it is both unhelpful and indeed potentially harmful. Could I get you to speak to really, just the origins of why you wrote the piece?
For sure. A lot of it kind of dates back to the part of the stuff we learned in school, but then also some of the stuff that that I saw kind of in my earlier into middle practice. And it's all about prioritizing that load and go patient, that we need to get that patient to the hospital as quickly as possible, because the sooner we get them there, the better their outcome is what we're told. And so naturally in school, in your scenarios, oh, the patient expresses pain here, oh, they express pain there. Well, sorry, you're just going to have to bite down because we have to move you into the truck and we're going to have to do all of our stuff once we get there. So best of luck kind of a situation. And then starting into practice and kind of moving on, you get into situations where the pain just becomes kind of a symptom that you can or don't necessarily have to treat, depending on the nature of the pain and the nature of the severity of the pain, and also the priority of getting them to the hospital. But then you get these patients to the hospital and you very quickly realize, oh, that broken hip isn't going to be seen for who knows how long because it's low on the triage list. And even once it gets seen, it's not going to be fixed until, whenever the next surgical time is available. So practically speaking, is there a benefit to getting that person to the hospital 5 minutes faster, or from sacrificing those 5 minutes to make them a lot more comfortable for the entire trip, knowing that they're going to be at this for quite a while and knowing pain is unpleasant. And it's something that some of us paramedics have fantastic experience in, having experienced it in some severely injured patients. But more importantly, if we ourselves have also been injured and understand, oh, the last time I broke my leg was absolutely terrible. Or I know a lot of the lady paramedics will speak of pregnancy pain. That's another massive one that gives people an idea of just what it's like to live with either long-term or chronic pain until it's finally dealt with, either with medication, with some form of surgery, and the impact that can have on a lot of people. And the research that's coming out on all the ways that medicine fails to treat a patient's pain, and specifically in history with neonatals and neonatal patients and babies, we've done a terrible job of treating or managing their pain. And this is all, it's surprising that there continues to be this short-sightedness, specifically because we just don't, we don't recognize or I guess value how amazing analgesia can truly be. Specifically, as I do mention in the article, the ability to block off pain receptors was a huge revolution for medicine, and it allowed us to perform so much more, but also just take the edge off of the simple, uncomfortable stuff. Because at the end of the day, the patient's not going to notice that you got them there 5 minutes quicker so they could wait in the hospital for 5 minutes longer. They're going to notice that you managed their symptoms, that you did the best that you could to make them more comfortable and take a little bit more time to get them there in a nicer manner than to sit there and say, well, our transport time was fantastic. We got them there very quickly. They're still in a ton of pain, but nobody dies from pain. And that's not the point. That's just what we've kind of told ourselves or allowed ourselves to kind of ignore, that medicine is not just that quick emergency, quote unquote, life-saving intervention. It's the whole package. It's being able to take the edge off the stress and the pain and the discomfort that the patients are experiencing, while also getting them to hopefully the next step in their medical journey.
And you also denote, Radu, in the piece, and I absolutely agree with this. The physiological stress response from pain can impede long-term and indeed even short-term recovery, and it actually can add to not only suffering, but like you said, it's just the convalescence and recovery can be stultified from that pain.
And I think it speaks to a lot of paramedic focus on kind of, again, that short term of getting them to the hospital. We don't pay attention to what's the long term, what are the overall impacts? Well, that's not relevant to us because, well, one, we've long since handed over the patient at that point, but two, we also just don't hear, or I don't know how many kind of long-term longitudinal studies have been done on, well, what's the overall benefit of a patient who receives adequate pain control from the start to somebody who gets it much later on. And, we only focus again on that immediate life threat to the patient, but we don't focus on, well, what if these patients are now less willing to call EMS because of their fear of being handled poorly or handled roughly, because, well, that broken leg isn't going to kill you, but it's still going to be very pleasant and very uncomfortable. And for this patient, that is still an emergency, because now they can't move. Now they're going through something they may have never experienced before. And our job is to be there to help with the psychological aspect of, hey, this is going to be really weird for you for a while. And it starts with you having had to call 911 for something. And then into the physiological, let's see if we can manage your pain and just help make this entire process easier from the get-go. And those moments that we have before we hand over care, those are the few times that patient is going to have a 2-to-1 ratio, a 1-to-1 ratio of practitioner to patient for a very long time in their medical journey. So that's the one time we have to really get the process started of, oh, you're quite uncomfortable. Well, let's get you really good and comfortable now, especially because we don't know when in the next few hours you may or may not have that access to subsequent analgesia, depending on how busy the hospital you take them to is.
So it's a fantastic piece, and you're going to hear it. You're going to read it in the show notes. There's links in the show notes to the piece. Radu, it's always a pleasure just to unpack these blogs with you. Thank you for your time today.
Thanks for having me.
Welcome to the Deep Dive. Today we're zeroing in on a single really common phrase you hear in emergency medicine, an EMS-ism, if you will. That phrase is, no one dies from pain. Sounds simple, maybe even true on the surface, but we're diving into an essay by Radu Venter from the Paramedic Philosopher that really challenges this. It argues this saying isn't just unhelpful, it could actually be, well, harmful, maybe even callous. So our mission today is to unpack why. Why does this technically true statement, in the strictest sense, kind of fundamentally fail to represent where modern EMS is and should be? Now, let's be fair. The phrase didn't come from nowhere. It originated from a real need, especially back in the day, or in really critical situations. The focus had to be on getting the patient to the hospital fast. Definitive care. If someone's bleeding out, you stop the bleeding first, right?
Right. Pain management, symptom relief. That understandably took a back seat, especially in training. You had to hammer home the life-saving priorities, stop the bleed, secure the airway. And that's where the nuance gets tricky. We have to acknowledge that little grain of truth. I mean, obviously, if the patient doesn't survive, pain relief is irrelevant. But the author really makes us look at what happens when that narrow training focus spills over into all of pre-hospital care all the time.
So it stops being a specific reminder and becomes more like a general rule.
Exactly. And that's when it becomes, at best, a misrepresentation of what we actually face. And honestly, at worst, it feels like a justification for letting people suffer when maybe they don't need to.
Okay, let's unpack that. The source calls it a straw man argument. So we agree pain itself isn't listed as cause of death on a certificate. But why is that distinction maybe not the point? Why is the statement flawed?
Well, like you said, it's kind of a straw man. It ignores the basic human element. Pain is awful, period. Suffering is bad. We don't need a medical textbook to tell us that. But the bigger flaw, the one we really need to dig into, is the immediate physiological cost. What does severe unrelieved pain actually do to a body that's already in crisis?
Right, it's not just a feeling, it's a biological event.
Absolutely. Pain is a massive stressor. Think fight or flight. When someone's in agony, their body is flooded with stress hormones, adrenaline, cortisol.
And that's not just about them feeling agitated or scared.
No, though it definitely does that too. It's a measurable physical thing. We see heart rates climb, blood pressure spikes.
Okay, so give us the hard impact. What does that stress response mean for, say, a trauma patient or someone having a heart attack?
Well, imagine that patient. Maybe they have internal injuries. Maybe their heart is already struggling. Maybe it's a head injury. Their body is working overtime just to keep things balanced. Then you dump all that adrenaline into the mix because of untreated pain. You're making the heart work much harder, demanding more oxygen it might not have.
And for the trauma patient?
That spike in blood pressure, it could potentially make bleeding worse or aggravate an existing injury. So the pain response isn't just unpleasant, it's actively working against stabilization.
That's a really critical point. And the source ties this back to medical history, which I found fascinating. It wasn't just about being nicer.
Not at all. The development of anesthesia and analgesia pain control was revolutionary for medicine. Why?
Because you can't do complex surgery if the patient is in agony and, well, fighting you.
Precisely. Early doctors figured out pretty quickly that managing pain was crucial for better outcomes. It allowed for more invasive life-saving procedures to actually be possible. It proved that reducing suffering helps people survive and recover.
So saying no one dies from pain just completely misses that. It lets us ignore something that's actively hindering the main goal.
Yeah, it treats pain like it's purely subjective, just a side issue. When physiologically, it's this potent stressor that's burning through the very reserves a patient needs.
And the impact doesn't just vanish once the ambulance doors close, right?
Oh, definitely not. We need to look beyond that initial transport. Long term, there's a real connection between poorly managed acute pain and worse outcomes later.
Like what? Delayed healing.
Delayed healing, absolutely. Higher risk of developing chronic pain, which can just devastate someone's quality of life long after they've technically recovered from the initial event.
And mentally, too, I imagine.
For sure. The psychological toll is huge. Intense, unrelieved pain can lead to more anxiety, fear, even PTSD symptoms. It can damage trust in the medical system, making people less likely to follow through with rehab or future care.
Wow. Okay, and then the source brings in something I hadn't connected before. Medical assistance in dying, or MAID.
Yeah, it's a powerful, maybe even stark connection the author draws, as MAID becomes more discussed or available in different places.
Pain is often a key factor.
Exactly. Persistent, unbearable suffering, even if it's not immediately killing the person, is very often cited as a major reason why someone might consider MAID. And that just crystallizes the whole argument, doesn't it? If society recognizes that pain can impact the desire to live so profoundly, how can we, as the first medical contact, dismiss it with an old slogan?
It shifts it from just an operational issue to something more fundamental, ethical, professional.
Right. So the source's conclusion feels pretty solid. Even if technically true in that narrow sense, no one dies from pain, is just. It's not a useful statement. It misrepresents what we should be prioritizing.
Let's talk more about that misrepresentation, specifically for modern paramedicine. The source argues it kind of relies on an outdated view of paramedics.
Yeah, the old ambulance driver model, where the main job was just transport. Get them from point A to point B, hospital fixes them.
And maybe the phrase fit better then.
Perhaps. But that model is, or should be, long gone. Paramedicine has grown massively as a profession. We're talking advanced skills, critical thinking, more autonomy, a whole field of transport medicine study.
So the job itself has changed.
Immensely. Paramedics aren't just scooping and running anymore. They're making complex decisions using advanced pharmacology, performing procedures before the hospital. Clinging to a saying that minimizes that role, it doesn't do the profession any favors.
And let's bring it back to the listener, maybe imagining themselves or a loved one as the patient. That idea of definitive care, when does that actually happen? Is it immediate?
Rarely. That's the practical kicker, isn't it? The phrase implies the seamless handoff straight into the OR or the cath lab.
But the reality is often waiting rooms, hallways.
Exactly. Emergency departments are busy. Even critical patients might wait hours, sometimes longer, before the definitive treatment actually starts or they get admitted.
So the paramedic's care window is often much longer than just the drive.
Right. And just letting someone suffer intensely during those hours because eventually someone else will deal with it, that feels, well, medically questionable and, frankly, unkind. The paramedic is often caring for them through that initial uncertain waiting period, too.
Okay, but let me push back slightly. If time is critical, time is muscle. Time is brain isn't taking time for pain meds. Even just a few minutes, potentially delaying that definitive care.
That's the classic dilemma, and it requires good clinical judgment. Nobody's saying you ignore a truly catastrophic bleed to give morphine. In those genuine load-and-go moments, transport is king.
But those aren't every call.
Not by a long shot. Most calls have some time. And we have pain medications now that work quickly and safely. Often the time argument is, let's be honest, sometimes a cover for maybe not being comfortable with the meds or not having clear protocols or just falling back on that old easy excuse.
So it's not about always prioritizing pain meds over speed, but about not using the old saying to justify never managing pain when it's needed and possible.
Precisely. And remember that physiological stress we talked about, relieving that pain, reducing that stress response. It actually makes the patient more stable, potentially better able to tolerate the wait for definitive care.
Which brings us to what the source suggests is maybe the core role or a key specialty for paramedics today.
Yeah, this is sort of the aha moment in the essay, I think. If you step back and look at what paramedics can actually fix definitively at the scene or in the truck, it's limited. They aren't doing surgery.
Right. They stabilize, manage immediate threats.
Exactly. So if definitive cure isn't usually their domain, what is? Symptom relief. Managing the awful stuff. The pain, the nausea, the shortness of breath, the anxiety, that becomes a primary therapeutic goal, not just a nice to have.
Making the unbearable bearable.
Yes. And that's where paramedics have a unique advantage. Unlike a swamped ER doc, they usually have one patient to focus on. They can really dial in that care, titrate meds carefully, offer reassurance.
So because they often can't fix the underlying problem right then and there,
their crucial role becomes making that patient as comfortable as we can along their journey. And comfortable isn't just about feelings, like we've discussed, it's about physiological stability.
less stress, better vital signs, better overall condition.
Exactly. We need to reframe pain relief not as just comfort care, but as a core part of stabilization and treatment. It reduces that harmful stress cascade.
So the takeaway for paramedics, the professional message, is actually quite positive.
Very positive. Instead of holding on to an old phrase that kind of downplays their skills, the source says, take pride in this. You're experts at managing acute distress and suffering. That's a vital, sophisticated skill.
Elevates the role beyond just transport.
Absolutely. They're mobile clinicians specializing in symptom mitigation during crisis. And recognizing that is key for the profession's growth, for training, and for individual provider satisfaction. We want paramedics who see managing suffering as integral to saving lives and improving outcomes.
So wrapping up this deep dive, we've seen how that simple phrase, no one dies from pain, while technically true on one level, really masks significant physiological risks and undervalues the modern paramedic's role. The evolution seems clear. Away from just being a transport technician focused on speed, towards being a symptom relief expert focused on mitigating suffering, to actually improve the quality of the life being saved.
And maybe the final thought to leave with you, the listener, connects to that bigger picture. If we accept that relieving suffering isn't just about being nice, but is evidence-based practice for better outcomes, for better recovery, does that shift our focus? Maybe it's not just about saving the life, but ensuring the quality of that life afterward. And makes you wonder, how often in many fields, not just medicine, does a focus on pure efficiency maybe allow us to excuse a lack of compassion or overlook profound suffering? Something to think about.
A really important question. Thank you for joining us for this deep dive today. We hope it gave you some things to consider. We'll catch you next time.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.